Okay, so my topic is a prolapsed umbilical cord. Prolapsed umbilical cord happens when the umbilical cord precedes the fetal presenting part and it gets trapped between the fetal presenting part and the maternal pelvis. And this compresses the umbilical cord and cuts off the supply of blood and oxygen to the fetus. Risk factors include spontaneous risk factors or iatrogenic risk factors. Spontaneous risk factors include the malpresentation of the fetus, a small fetus, which could be from intrauterine growth restriction or from a small for gestational age fetus, prematurity of the fetus, or from fetal anomalies. The iatrogenic risk factors are the risk factors that arise because of the medical interventions that we take. These could be from an amniotomy, from the placement of a intrauterine pressure catheter or the fetal scalp electrode, or from the Leopold's maneuvers that we do to change the fetal presentation. The article that I read, it says that about half of the cases of an umbilical cord prolapse can be accounted to iatrogenic factors. So the management of a prolapsed umbilical cord, like I mentioned before, cord prolapse compresses the blood vessel in the cord and it cuts off the blood supply, and so it causes fetal hypoxia. And if it's not treated immediately, it can lead to long-term disability or even death of the fetus. So once an umbilical cord prolapse is identified on a vaginal exam, sometimes you can see the cord itself, or you would feel the cord when you're doing a vaginal exam. Once it's identified, the article says that the fetus should be delivered as soon as possible. So in most cases, you would be doing a C-section, but the article does say that a vaginal delivery can still take place if the provider feels like the vaginal delivery is imminent and it will happen quicker than the time it takes to set up for the C-section and do the C-section. Um, as nurses, one of the most important steps that we can take is to relieve the compression on the cord by pushing the fetal presenting part off of the um, umbilical cord. There are a couple different ways that we can do it. Manual elevation would be to use two fingers, put two fingers into the vagina and push the fetal presenting part off of the cord. There's also the bladder filling technique, which is also known as the Vagos method, in which you would put a Foley catheter in the bladder and fill the bladder with 500 to 750 mils of saline, and then clamp the Foley catheter. So you can use the bladder to push the fetus off of the cord. The article does say that in this method, they think that this can also, the filling of the bladder can also relieve some of the contractions of the uterus, which will also help with relieving the compression on the umbilical cord. We can also use gravity to help pull the fetus down off of the cord. There are two ways that we can do it, either by placing the bed in a Trendelenburg position or having the mom assume the knee chest position. The article that I read, it says that there were studies that were done to compare the effectiveness of manual elevation versus bladder filling, and they found out that the outcomes were about the same. Regardless of what techniques that we use, we should always use the fetal heart rate monitor to make sure that the compression on the cord is effectively relieved and that the baby's heart rate is not dropping too much. So in conclusion, cord prolapse is a medical emergency and we need to act quickly to make sure that the outcome is favorable for the fetus. Some of the priority nursing actions are first and foremost to elevate the fetal presenting part off of the cord and relieve compression on the cord. We should start monitoring the fetal heart rate to make sure that we are effectively relieving compression on the cord. We should notify the provider and the team, and we should get ready for the immediate delivery of the fetus. These are my sources, and thank you.